I think that one thing that's very important for you all to know about me is I genuinely and truly do not believe that I've ever had an original idea in my entire life. Everything that I know and do is shamelessly copied and imitated from people around me. Some of those people are my parents, my mom and dad. So my mom is the genius behind the whole operation. You know, all of the cases that we do them in our office. We do them in our clinic, all of the surgeries. And that's not because of me or dad, it's because mom has figured out how to get them paid. So if you're wondering, well, I just don't think that we could get this operation. Mom has figured out how to get PK paid in the clinic, okay? Mom has figured out how to get all of these things paid, and that has decisively shaped our practice more than whether we're doing DMEC or DSEC or whatever. It's her shaping. And you know, my dad, he started this practice, and I joined him after I did a fellowship. And I remember I asked Dad when I was in high school, you know, because growing up I would go to these American ophthalmology conferences with Dad, and I remember we were in New Orleans for some conference, and we were walking down the street after one of the meetings, and I asked Dad, I said, Dad, what are you most proud about in your career? And he said, I'm most proud that I've never done RK. And and you know, it's like, I think he really genuinely means that. But you know, Dad did his cornea fellowship at Hopkins, but what distinguishes him is that he comes across as this very conservative, reserved, but he is the most radical. You know, Dad was the first person to do DMEC in Alabama. I mean, I think the first person to do DSEC in Alabama. One of the first people in the state, or in the country. He's the first person in the United States to do CAIRS. He's the first person in the United States to do Bowman layer transplantation. So all of these things that I'm going to talk about are just the product of Mom and Dad's insights. And one other person, by the way, that y'all should know about is this guy in the front. This is Philip Dockery. So he is our fellow. Philip, raise your hand. So Philip, he's this young looking guy. Okay, he looked a lot younger 10 years ago when he started working for us, okay? So Philip, when he was a third-year medical student, the most trouble I've ever gotten in my career was when I was letting Philip do some of my PKs in the hospital as a third-year medical student, okay? Because he is just the most smart, talented, impressive person I've ever met. And this presentation is also going to be about some of the things I've learned from Philip. So, the original CAIRS technique was developed by Susan Jacob. And y'all know about Susan, how wonderful, brilliant, nice, generous, sweet she is. And in her original manuscript, one of the things that she just sort of mentions as this throwaway aside is that, oh, by the way, the femtosecond laser is used for the creation of these intrastromal channels into which you slide these collagen segments. However, this little seemingly insignificant detail has been exploded. It's been glamorized. You have people celebrating femto-CAIRS. And maybe that's because femto-CAIRS is fun to say. It sounds complicated. It sounds like a complexity advanced to the original procedure. It looks scientific. Everybody loves lasers. And in fact, there are all femtosecond CAIRS versions of the operation, or femtosecond CTAC. And that's when you would use the laser to prepare the donor tissue as well as the recipient eye. So you probably expect me to say that, well, which one you do depends on the patient, or it's surgeon preference, or maybe you expect me to be controversial and iconoclastic and say femtosecond CAIRS is bad and you should never do it, and here are the top 10 reasons why. When in actuality, my position is much, much, much milder and tamer, and that is that femtosecond CAIRS may be better. I don't know. I've never done it before. I've never done femtosecond CAIRS, not once. I've never seen it in person, not once. And the reason that that's the case is because when Dad started with CAIRS 8 years ago, we were doing the procedure at the eye hospital. And the eye hospital didn't have a femtosecond laser. So if we were going to do it, we had to use a manual technique. We had to use the same technique that was devised originally for Intacs. And it seemed to work well for Intacs. And we thought, well, let's see if we can make those same channels the way we were making them for Intacs also for CAIRS implantation. You know, I think if you want to evaluate the difference between manual implantation and a femtosecond laser implantation technique, There's no doubt that using a laser sounds a whole lot easier clicking a button than doing any kind of cutting or screwing or twisting on the eyeball. I mean, I don't think anybody would doubt that using the laser is an easier way to do this procedure. But you know, one of the reasons why we haven't been tempted to switch over to use the laser ourselves now that we have 8 years of experience doing the operation, do the procedure all the time, is because the manual technique works so well. We just really haven't been inspired or motivated to look for anything better or different because we like what we're doing now so well. One of the reasons why we like it is it's so fast. It's so fast to use a manual technique for tunnel creation. It takes 60 seconds to do. You're not schlepping the patient from room to room or priming the laser or entering patient details. It's lightning fast, and it's basically free because there's no click fee that you have to pay. You know, what we currently luxuriate in is the $30 Intax vacuum tubing that we buy. We pay 30 bucks a case for the vacuum tubing. And we were afraid, actually, relatively recently, that the company was going to discontinue the vacuum tubing. So we were looking at reusable silicone tubes that we could autoclave. So I think we really wanted to, we could get our case cost down to zero. And I think this is important because, you know, what Mom was talking about is how are you going to deal with insurance payers? Well, we went through a year-long period where nobody's insurance covered this. Okay, this is like COVID, 2019 or 2020. Nobody's insurance covered it. Did we stop doing the surgery? No. What we did is we started billing the patients cash. We said your insurance doesn't cover the procedure. It's not covered. If you want CAIRS, you have to pay cash. If you're having to bundle in a click fee, then it's a much higher price for the patient. Now, the tissue that we get from the eye bank is, I'm not sure, $500 or something like that. Our case cost is $100 to do the operation. You could charge the patient cash out of their pocket if their insurance doesn't pay for it, much easier if you're not using the femtosecond laser. Normally, when we're doing these surgeries in our office, it's not uncommon at all for us to do 7 or 8 in a day. And we operate every week. So every week, we operate on Thursday, we're doing 7 or 8. Phil, how many did you do of these on Thursday? Do you remember? 4. So Philip did 4. We had a visitor from South Africa, from Rwanda actually, visit with us 2 or 3 weeks ago. And he spent the day with us in surgery, and he came over from Rwanda to learn how to do CAIRS. And he said, Dr. Parker, you've got to be the highest volume CAIRS surgeon in the United States. I said, no, definitely not. It's definitely not me. It's Philip Dockery. Philip is the highest volume CAIRS surgeon in the United States, okay? But we do these all day long, every day. We don't have time to be taking somebody back and forth to the laser. We've got to do things quickly and efficiently in situ in the room. So the way that we started doing this operation at Parker Cornea was the way my dad figured out how to do it, okay? And here is a video that was shot a long time ago. This is kind of the technique that we developed after having done it for a couple of years, okay? So when we started this operation and I started learning how to do it, we did this surgery at the eye hospital under general anesthesia. So in a normal surgery day for me now, when I'm operating on Thursday, it's completely normal and regular and routine for me to do 20 DMEX. Okay, it's like a normal day for me, is 20 corneal transplants, okay? We have YouTube videos that show an unedited, start to finish DMEX surgery in 2.5 minutes, okay? So we do quick DMEX at our facility. When I started doing these CAIRS operations, the surgery took me 1.5 hours under general anesthesia, okay? So it's gotten a lot better than how it started. And I'm gonna show you some of the ways that this has changed over time, okay? So this video from a couple of years ago shows the start of the case. Starts here with a sub-Tenon's block, okay? So already an improvement over general anesthesia. We mark the center of the cornea with this zone marker, and then we ink the center of that epithelial impression with a gentian violet tipped Sinskey hook. This is a zone marker, and we kind of put that centrally on that purple ink spot and then make this radial incision with a guarded diamond knife. And then over the top of the eye, we fit this suction ring connected to our vacuum tubing, and we turn it on, and that holds the eye, not just in place, but it stiffens the cornea and makes it more rigid. And then we use this thing Dad calls the shoehorn to slide this corkscrew dissector into that initial 1 millimeter pocket and then spin it around. And it's very important here to stay planar, not angling up or dipping down, so you stay in the same location in the cornea. And once you slide it along, then you just back that little corkscrew dissector out of the eye, and then take this little segment, which is, you can see here, thin and stiff and stained blue, and slide it into that pocket. You can see it actually looks and behaves very much like an intact segment here, okay? And this is the eye with the segment in place. We don't suture the wound, we leave it just like that. We don't patch the eye shut, no contact lens, just topical moxifloxacin, and that concludes the operation. Now what you just saw, this sort of modified 10-minute long technique was scientifically described by guess who? Dr. Philip Dockery back in 2019, okay, back when he was a medical student, okay? And not only did he describe the manual implantation when it was a little more sophisticated, he also described staining the segments, okay? Because before, we were putting these big, thick, chunky, clear segments into the patient's cornea, and you couldn't see what the hell you were doing. So it turns out if you stain them blue, you can see them a lot better, and if you thin them out, they're easier to get into the cornea. Now, whenever I talk about CAIRS, people want to know, okay, exactly what instruments are you using? Tell me the model number, tell me precisely what it is, okay? Most of the instruments that we currently use come from this Spanish company called AJL. Dad is exactly right. If you call them on the phone, they are indignant that you would have the audacity to order anything from them, okay? But this is what we use, okay? In order, the first thing we use, actually not AJL, it's a Duckworth and Kent product, it's this zone marker, okay? I don't think you have to use this. This is what we use, okay? It's this exact thing. Then we use a Sinskey hook. I don't know what Sinskey hook we use, but it's a normal Sinskey hook looking thing, okay? So after we use the zone marker from D&K and some regular Sinskey hook, then we use this, I think it's called a zone marker. Dad and I, we call it the marked other thing. We asked the scrub tech, give me the marked other thing. They know what that is, okay? So that's the marked other thing, okay? And then we use a diamond knife, okay? Is there anything special about this diamond knife? No, okay? It's just a micrometer blade. We like using a micrometer blade because it allows us to determine more precisely the depth of the incision that will then slide the CAIRS segment into. What we normally do is, or at least me, I like to use the Pentacam. I use a Pentacam printout that we take on all patients on the morning of surgery. Everybody comes in, they get a Pentacam, we look and see how thick the cornea is, kind of where we're planning on making the incision, and we measure 60% of that thickness. And that's the level that we set the diamond knife to. That's what I do. That's a little bit more futzing and fooling. Dad, he just sets the incision to about 400 microns on everybody. That's a lot faster. And 400 microns works for basically everybody, so probably I should copy Dad again. The other things we use are this vacuum centering guide, okay, and a vacuum pump, okay? These are also AJL products. These are exactly the ones you need, okay? Now this vacuum pump, if you do have the temerity to contact AJL, they will quote you a price of $11,000 for this vacuum pump, okay? So if you buy all the stuff from them, the bill is going to be like $18,000 or $19,000, and of that, $11,000 is this vacuum device, okay? We don't have one of these. We have two of these that we bought on eBay for $120, okay? There are people in this room that have taken my advice and bought one of these on eBay also for $120, okay? So we like using these because they're very durable, they're inexpensive, you can find them on eBay. Keravision, I took this picture, this one's broken, don't buy this one, okay? But I took this off the internet 2 days ago, okay? Now let's say you don't want to spend $11,000 on a vacuum pump from AJL and you don't want to buy something off eBay for some reason, okay? What else could you do, okay? Well, Eric, the genius Eric, has also figured out that you can make a little vacuum pump just using a suction syringe. And he's made a video, and Karen DeMarco shared it with me, and this is on her YouTube channel, okay? So if you want to watch the video that shows exactly how you make your own vacuum suction without buying anything from anybody, this is the way you do it. Now, into this suction ring, whether you're using a vacuum or not, the next thing you're going to do is put these little corkscrew dissectors, which are technically called corneal separators. These are not delicate things. They're stainless steel and they have a thickness to them. They're meant to be ramrodded through the cornea. However, you may have occasionally noticed in your own surgical experience, you get back some titanium instrument that has been bent or gnarled or dropped on the floor or intentionally destroyed, okay? And so in order to ascertain whether or not these corneal separators are true, in other words, whether they have the proper curvature and are going to dissect the channel that you think they're going to dissect, there's this little inspection gauge that you put down in it and you twist, and it will twist around if the separators are not bent, and it won't twist if they are bent. So we check them always before we start using them that they're true. Almost done. The last things are, there's something called a pocketing hook, which looks just like a long Sinskey hook, so we call it the long Sinskey. And there's something called the symmetric glide, which we call the shoehorn, okay? And these are the item numbers if you're going to get them from AJL. Now, I know I've just given you this very dry, boring recitation of ingredients, okay? And you think that seems complicated, but this really is not a complicated surgery. And the way that I want to convince you of that emotionally is I want to show you the surgery not being done by Dad or me or Philip or Mom. I want to show the surgery being done by our PA. We have a PA. Her name is Emma Scott, okay? She's 25 years old. We hired her directly out of PA school, okay? She has no ophthalmology experience whatsoever. She's been working with us for 2 years. This is Emma. Emma's single. She has boy troubles, okay? So we hear all the time about Emma's young person life, okay? And this is Emma doing this surgery 2 weeks ago, okay? Here it is. She's making a mark on the surface of the cornea, just like me. Here she's dotting the center of the eye, then she's lining it up with a marked other thing, okay? And then she's gonna hold the eye with this Thornton ring. Here's Emma making the initial incision into the eye. She's got the suction ring on. Here's the long Sinskey hook that she's using to dissect this 1 millimeter pocket right adjacent to the main wound. Then she's gonna stick the shoehorn into that little pocket. She's wiggling it in. And now she's turning that little corkscrew dissector around. Almost done. By the way, PAs in Alabama can't use the laser, okay? So if we had a femtosecond laser, she couldn't do this, all right? But because we don't, and look here, see this now we're putting the segment in? This is actually where Dr. Dockery came in and took over. He's putting the segment in because he's the surgeon. He's got to do the real important part of the operation, okay? But 99% of the surgery is done by our 25-year-old boy crazy PA, okay? So you do not have to be Garrett Mellis in order to do this operation successfully in your office under topical anesthesia, okay? Now, why does it take Emma 6 minutes to do this operation with me not in the room when it used to take me an hour and a half to do the surgery under general anesthesia? Well, one reason is we figured out that the key thing is to dry the segments out. And by we, I mean Philip, okay? So if you have the segments that are thick and sloppy and wet, it's very hard to get them into the cornea, okay? It's like pushing a wet noodle, okay? The segments don't want to go into the cornea because that's just a potential space you're dissecting. It's not a cavern. There's no actual room in there, okay? So you have to force them through. But if you got this slippery, wet thing flopping all around, it's very hard to even get it into the wound at all. And then when you start trying to push it, it just kind of bunches up on you. So we used to make one incision temporally and one incision nasally and kind of push it part of the way and pull it the other part of the way. We used to tie the segments to capsular tension rings or to intact segments, and we're thinking about designing all of these special instruments. You don't got to do any of that crap. All you have to do is dry the segments out. If you dry the segments out, they become stiff and thin. The cornea is 80% water. If you dehydrate it, the segments lose 80% of their volume, okay? So it's much easier to feed them into the cornea. Plus, you can use overall thicker segments. You know, when you order these CAIRS segments, the eye bank is going to say, all right, what kind of segments do you want? How big do you want them, okay? Well, you would like to use the thickest segments you can, okay? Because the thicker the segment you put in, the greater the effect you're going to have on the shape of the eye. So the bigger the segment, the more topographic impact. However, the bigger the segment, the harder it is to get it into the eye, okay? So you can use little thin measly segments. In fact, your first cases you probably should, okay? But you can also get away with using much, much bigger segments. Get the big ones and then dry them out, and they behave much more friendly. Now, you'll notice here in this picture, this is me operating in this picture, okay? And I've got the segments drying here on a Wexel sponge, which leads me to something interesting that I learned, which is that it's possible to put sponge debris into the cornea, okay? So this is me publishing this, okay? These are my eyes that I notice have got these weird little white things in the cornea after I've done CAIRS on them. What are those things? They're pieces of sponge, okay? So if you want to sort of communicate to a layperson, you know, what's an example of medical malpractice, surgical incompetence? What you would say is the surgeon left a sponge in me. That's what you would say, okay? And it turns out that these cellulose sponges, these Wexel spears, okay, are flaky. And if you dry the segments out on the cellulose sponges and you put them in the eye, they bring sponge pieces with them into the eye, okay? Now, mercifully, it's benign, but it sure as hell is embarrassing to see the patients with sponge debris in their eye after the operation. Consequently, I recommend a few things. Number one, do not use cellulose spears. Use Maricel sponges. Everybody who's a LASIK surgeon already knows that, okay? We don't do LASIK in our practice, so I had to learn that the hard way, not to use cellulose sponges, okay? But there's an even better way, okay? Dr. Awad, y'all all know Shadi Awad, okay? He has developed a way of drying the segments which has revolutionized our practice. What has he figured out, okay? Well, the first thing he's figured out is there is this device made by Epsilon. Here's the model number. This metal thing is supposed to be for shaping the CAIRS segments, okay? See, it's got like little degrees markers on there. And so if you watch Susan Jacobs' videos, she'll say, oh, customize CAIRS, and you can cut shapes and you can cut different arc lengths and blah, blah. And these are like little markers for cutting those shapes and arc lengths, okay? That's why it was developed, okay? But that's not its best purpose. Its best purpose is this thing is a prodigious conductor of heat because it's metal, okay? So you take this metal thing, you put the CAIRS segment onto the metal thing, and then you put it on this coffee warmer. This is the one you want. It's medical grade. No, it's from Amazon, okay? Now you might say, well, Jack, is that your medical opinion? No, this is what Shadi Awad published. This is the one that's in his paper on the subject. This is it, okay? So when the FDA comes and asks, you say, well, it's published. It's this one, okay? What do I like about this coffee warmer? Number one, it's the one that Shadi Awad published, so I know I'm not going to screw it up by getting some dumbass thing in there, okay? The other thing that I like about it is that it's got a temperature gauge. You can adjust the temperature, okay? And we use a temperature of 145 degrees, okay? And by we, I mean Emma. Emma comes and takes the segment out of its albumin solution, okay? And I've got a video that's going to show how she prepares the segment. This is what we put it on, okay? And it cost $22, so we bought two. We splurged, okay?